Hello everyone, myself Dr. DP Rai, consultant cardiologist from Gantok, Sikkim. I am sharing this clinical experience on this podo site. Mr. AB, 58 years old, patient, history with the type 2 diabetes mellitus since 4 years, obesity, hypertension, hyperlipidemia, and obstructive sleep apnea. On physical examination, BMI is stable at 32 kg per meter square, BP 130 by 82 millimeter of mercury, heart rate 60 beats per minute. On laboratory examination, HbA1c was 8.3%, eGFR was 70 millimeter ml per minute, LDL 69 milligram per deciliter, SDL 35 milligram per deciliter, triglyceride 250 milligram per deciliter, AST, ALT 70 by 100 unit per liter respectively. Patient on medication like metformin 1000 milligram twice daily, lisinopril 40 milligram once daily, metoprolol 100 milligram once daily, atorvastatin 40 milligram once daily, aspirin 81 milligram once daily. On this patient profile, he has a short duration of type 2 diabetes. He is young. He has no major comorbidities with no major complication that would reduce his lifespan. He is at low risk for hypoglycemia. He would benefit from more stringent goal. However, he is also obese, hypertensive, hyperlipidemic with obstructive sleep apnea disorder. American Diabetic Association recommendation, less than 7% is reasonable goal for most non-pregnant adults. In addition to efficacy, following consideration predominates in determining the pharmacotherapy for him, such as risks of hypoglycemia, weight loss, minimize weight gain, heart failure, atherosclerotic cardiovascular disease, CKD, etc. Mr. AB is willing to start another medication, but is concerned because he forgot to take his pills and fear that additional will only make this worse. He doesn't want to have an injection therapy. Fixed dose combination may improve patient adherence to once daily dosing, less complex treatment regime, fewer pills, improve side effect profile and adherence. People with type 2 diabetes mellitus commonly live with multiple comorbidities, among with hypertension and cardiovascular diseases are the most common. Monotherapy cannot address these multiple defects and often lead to failure to maintain glycemic control over time. Current diabetic guidelines encourage early adoption of oral combination therapy while simultaneously emphasizing the importance of individualized treatment. American Diabetic Association recommendation, in appropriate high-risk individual with established type 2 diabetes, decision to treat GLP-1 receptor antagonist or SGLT2 inhibitor to reduce major atherosclerotic cardiovascular events, heart failure, cardiovascular death, CKD progression should be considered independently of the baseline HbA1c or individualized HbA1c target. INFA and LINA is available as a first-in-class treatment in SGLT2 and DPP-4/1 combination group of drugs. SGLT2 is a class of novel oral glucose-lowering agent that mediates glucose-lowering action by increasing urinary glucose excretion via inhibition of sodium glucose cotransporter 2 in the proximal tubule of the kidney. The salutary effect in its ability to act independently of the insulin secretion and action rendered it suitable to administer at any stage of disease course. And DPP-4 inhibitor exerts its glucose-lowering effect by the elevation of the incretin hormones and subsequently augmentation of glucose-dependent insulin secretion and inhibition of glucagon release. Combination of this agent has potential to show the additive glycemic control due to their complementary effect. Infaglubation cardiovascular outcome event trial in type 2 diabetes mellitus, like INFARECT outcome trial, reported that 3 major MACE outcome occurred in a significantly lower percentage in the infaglubation compared to the placebo on the top standard care. In addition, cardiovascular safety of linagliptin, a DPP-4 inhibitor, was further elucidated in Carmelia and Carolina trial. HbA1c decrements by INFA-LINA 25 by 5 milligram combination has demonstrated 1.81% HbA1c reduction in HbA1c baseline at 24 weeks in metformin treated group. It benefits on glycemic control were maintained at the weeks 40 to 52 in metformin treated group, and a higher percentage of patients achieving HbA1c less than 7 were reported for combination. The combination offers a suitable component in strategy to achieve target HbA1c without increased risk of hypoglycemia and weight gain with improvement in overall lipid profile. A reduction in incidence of genital infection associated with SGLT2 has been reported when a DPP4 is added, perhaps because of better glucose control, although other possible mechanisms remain to be investigated. In summary, INFA and LINA combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the goal of HbA1c compared to individual agent with low hypoglycemic risks. So with that, we can conclude like this. So the in this era of disease with a multiple cardiovascular risk factor, patient having a multiple risk factor, and patient on multiple drugs on medical therapy of this risk factor for cardiovascular disease. So a combination polypill concept is a very good strategy to adopt on this patient having multiple risk factor like diabetes, heart failure, hypertension, obesity with obstructive sleep apnea. They are high risk for heart failure and heart failure hospitalization. So combination of multiple drugs in a single pill as a polypill concept is very good for patient adherence because they have to take a lot of medication and it results in a lot of discomfort and poor adherence and from the patient. So this polypill concept of this combination of empagliflozin, which DPP4 inhibitor with a SGLT2 inhibitor is a very good combination for controlling heart diabetic patient glucose control, as well as those with patient of heart failure with the diabetes is a very good polypill regime for those patient this where this medications are indicated. Thank you so much.